Good afternoon and welcome to another Evergreen Talks here on the Evergreen Family Medicine platforms of YouTube and Facebook and now Rumble. On Evergreen Talks, this is a program that is produced on the second Thursday of every month at 4 o'clock when the physicians, providers, and specialists at Evergreen provide information and present topics of interest to you. And as always, we'd like to send people to our website, evergreenfamilymedicine.com, for more information. Today, we welcome Dr. John Powell to Evergreen Talks for revisiting informed consent and what happened to herd immunity. And for those of you who are watching right now, you can leave comments and questions in the chat on any of the platforms that you're watching. And Dr. John plans on responding to some of the frequently asked questions that come from this presentation. But with that, I'm going to turn it over to you, Dr. John. Thank you for your time today.
Thank you, Brian. During my previous town hall presentation, I alluded to the challenges of having a public conversation about COVID. The terms misinformation and disinformation have been over-applied to these topics. It presents a potential barrier to communicating medical information. Tension may increase as physicians weigh their own ethical obligations to provide informed consent and still be responsible about sharing medical evidence. Data presented today may conflict with an official political or public health narrative at times. It's hard to know for sure because hopefully these institutions continue to change their medical perspectives as well. Going forward, doctors may ultimately need to decide if we're going to remain true to our professional oaths or just be messaging tools for top-down groupthink policies. Will we only share medical evidence that endorses an approved narrative? Or are we going to have complete discussions with those that we serve? There's increasing evidence of conflicted institutional entities who have assumed a primary role in deciding what represents the correct medical opinions. I'm sorry to inform you that this is no longer a hypothetical concern. It's become a reality. This bill was passed last month in California. I'm going to read it just a bit here because it's important. It shall constitute unprofessional conduct for a physician or surgeon to disseminate misinformation or disinformation related to COVID-19, including false or misleading information regarding the nature and risks of the virus, its prevention and treatment, and the development, safety, and effectiveness of COVID-19 vaccines. This concerns me because Oregon oftentimes follows California's lead. This bill was passed by California Senate 32-8 and the California Assembly 53-20 last month. Assemblyman Evan Lowe, who sponsored the legislation, said it would give medical boards in California tools to discipline doctors who promoted misinformation or disinformation. Do California citizens realize that this bill tells them that they do not deserve a second opinion? Who precisely will be the arbiters of misinformation and disinformation? I doubt that it will be the physicians and scientists who are closest to the problem, and those who are empowered by this bill will be at risk from being captured by unscientific political forces. I was taught to embrace second opinions as a physician. The process was really not about hurting egos. It was about making the most informed decision to achieve the best medical outcome. Politicians have stuck their nose where it doesn't belong. Science is not an answer. It's a way of thinking. But given the implied physician gag order during this pandemic, I want to remind viewers that this presentation is not meant to provide any personal medical advice. People should seek the guidance from their trusted physician or medical provider. They should expect and receive answers to their questions in an honest and transparent manner. I want to start by acknowledging where we've been. I'm grateful to work with dedicated professionals who have served our Southern Oregon community during this pandemic. This slide represents people who were treated in our urgent care and hospital for COVID infections. The total to the right, the 6,074, represents approximately 25% of all the positive cases identified in our county through the month of August since the pandemic began. The last line represents all encounters seen throughout our organization. It includes pediatric care, women's care, family and internal medicine, endocrinology, urgent care, and hospital care. We continue to care for patients in person, as well as using telehealth medicine, because other medical problems did not stop because there was a new pathogen to deal with. We found that early treatment was effective. We implemented monoclonal therapy since February of 2021. We treated patients based upon the phase of their disease and not where they were treated. We used steroids, fluids, nebulized therapies, oxygen, repurposed medications based upon peer-reviewed medical evidence in controlled studies. We were not interested in controversy, but we wanted to bend the patient disease severity curve as much as possible to avoid hospitalization. As a hospitalist, I could see that late treatment was much less effective than intervening early. Sending patients home until their oxygen saturations were less than 90% was never a good strategy, and so we took a different path. I made these points during my previous 2 town hall presentations in January and May of this year. I stand by these opinions. I think many who argued against these perspectives are coming to recognize that lockdowns, school and small business closures, vaccine mandates, quarantining the well, social segregation, and certainly scapegoating were ill-advised during this pandemic. Today, I will briefly review some of the epidemiological data, expand on informed consent, and provide some thoughts about what happened to the concept of herd immunity. This data comes directly from the Oregon Health Authority website. I want to remind people that COVID does not impact everyone equally. Early on, there seemed to be a coordinated effort by the media to sensationalize unrealistic perspectives to the public. By headlining the exceptions, public anxiety and fear increased. By emphasizing the rare young person who became seriously ill, parents were frightened for the lives of their own children. We do not do this for potential adverse effects of vaccinations. Why was it done for this virus? I want to emphasize to everybody that many exceptional physicians and scientists pointed out that there was a significant age severity differential in the spring of 2020. They presented actual data from cruise lines and the population antibody study cohorts, but they were slandered, they were pilloried, and characterized as irresponsible. Institutional modeling was elevated above the actual data. This OHA case fatality data confirms an over 1,000-fold difference in mortality, case mortality between the young and the old in Oregon, just like the signers of the Barrington Declaration suggested. Modeling case fatality rates early in the pandemic were incorrect, and it drove the wrong public health policies. This represents disease severity over the course of the pandemic. As you can see, people are still being hospitalized, receive critical care, and at times require mechanical ventilation. The majority have been vaccinated, and many have received boosters. They also still visit the emergency department with COVID-like illness. So despite high vaccination rates and recovered immunity, we have not been able to eradicate the virus. We have about the same amount of COVID-like illnesses visiting the emergency department as we did during the spring and summer of 2020 during the lockdowns. This slide shows vaccine uptake by county throughout the state of Oregon. Douglas County's data is on the left. As a comparison, Multnomah County in the Portland area had a 90% uptake in one-dose vaccination. Douglas County is about 61% for those over the age of 18. But for those over the age of 65 in Douglas County, nearly 70% have completed their primary series, and 48% have been boosted. In Multnomah County, in the same demographic over age 65, 90% have completed their series, and 75% have received at least one booster. At the beginning of the vaccine rollout, I thought the process would be pretty straightforward. Vaccinate those over age 65 or those at high risk, like we do with other vaccines. In essence, it would be a focused protection approach using a vaccine tool. We had hoped that the vaccine would stop infection and transmission of the virus, but lately we can see that that has turned out not to be the case. Do you remember in the spring of 2020, there was a headline in our local newspaper, the News Review, that suggested that Douglas County, Oregon, was projected to have the fourth worst mortality rate in the United States? This was likely due to our elderly demographic and, frankly, our poor overall health status. We certainly can work on our rates of smoking, drug and alcohol abuse, obesity, diabetes, and we could exercise more. But as an example, the Oregon Health Authority data that we just looked at suggests that the case fatality rate in Multnomah County is about 1%, while the case fatality rate for Douglas County is approximately 2%. Since the beginning of this pandemic, the population fatality rate, that includes the entire population of these counties. For Multnomah County, it's approximately 0.17%, and for Douglas County, it's about 0.3% over the course of the last 2.5 years. Given the differences in age demographics, which is the leading predictor for COVID infection mortality, we see that the population fatality rate differences are even less based upon age disparities. This slide shows that 33% of the population in Douglas County is over the age of 65, whereas Multnomah County's population in the same demographic is about half that of Douglas County. Their 65 and over demographic represents about 16.5% of their population. I just provide this information for perspective as we discussed the informed consent process and we consider therapeutic options in the future. So as infections continue, people are trying to evaluate the risk and benefits of various therapeutic options for COVID-19 infections. I will focus on COVID vaccines today because many people want to have a broader discussion about this topic, particularly as they consider their children's circumstances. Some of the vaccine modifications and some of the new vaccine options. And I'll be happy to talk about some of the outpatient antiviral therapies for early treatment of COVID at another time. Public health institutions have changed the definition of vaccines. They did this because the vaccinations were not found to prevent infection and transmission for the more recent COVID variants. The vaccine had previously been observed to reduce severe disease, particularly during the Delta surge. At this time, I think these vaccinations fit a little bit better as a potential therapeutic intervention given the transmission realities that we're seeing. But I'm going to continue to call them vaccines during this presentation for ease of communication. So I'm going to speak to the current state of vaccine efficacy against the Omicron variants. Based upon my own clinical experience and the epidemiological data that I've reviewed, the COVID vaccine saved lives and prevented hospitalizations during the COVID-19 surges, particularly during the summer and the winter of 2021. But in the summer of 2021, we were starting to see breakthrough infections due to a very transmissible Delta variant in both the urgent care and the hospital. The infections were, in general, less severe than those, less severe in the vaccinated people. But by August 2021, we were observing our community impacted by this evolving virus that increasingly evaded the vaccine coverage. The incidence of infected individuals who had been vaccinated within 2 to 3 months of their visit to the urgent care with a COVID infection was clearly increasing. We saw a virus that seemed to be mutating in front of our eyes to more transmissible variants, and it caused more severe disease in younger people. The evolution of the COVID-19 was expected because all coronaviruses are highly mutable RNA viruses. But it was extremely disappointing that the vaccines did not prevent infection or transmission. So it was at this point in the late summer of 2021 that I agreed with a minority viewpoint held by other physicians and scientists. I did not see how herd immunity could be achieved by vaccinating everyone if it could not stop the chain of transmission. I was not ill-informed. If the vaccines don't stop the chain of transmission, herd immunity is not achievable in this population. There needs to be sterilizing immunity. But public health officials wanted to hit the 80% target for vaccinating the population. But they didn't, inexplicably, count natural or recovered immunity. So now the predominant variant remains Omicron BA.5. It's mutated enough that the existing COVID vaccines are much less effective. This represents an example of viral immune escape. Over 80% of the people who visit our urgent care with COVID infections have been fully vaccinated, and many have been boosted twice. So the vaccine mandates still exist for many. Personal health decisions have been coerced. So much division and unnecessary stress. I found this next British Medical Journal article interesting. The survey asked people, why do they choose to be vaccinated? This is what they found. So in late fall of 2021, the question was asked, why did people choose vaccination? 83% of the responders were vaccinated. Of those that wanted to be vaccinated, 30% reported health improvement, mostly due to the relief of the psychological stress and their ability to rejoin society. Of those who did not want to be vaccinated, 16% had reported a previous serious side effect. In our country, public health officials and public policy makers seem to start by promoting vaccine with really good intentions to inform. But when the uptake waned, they resorted to a carrot and stick strategy. Students and the general public were offered the possibility of tuition money, lottery winnings, and other enticements. Then the public shaming began, and to my amazement, scapegoating did occur. It was the pandemic of the unvaccinated. Mandates were imposed. They seemed to dismiss the evidence of breakthrough infections as just not high enough antibody levels. But another valid concern was that it wasn't the right antibody. And many thought that cellular and innate immunity that I've discussed in previous presentations were critical as well. But policymakers pushed on. They surmised that the higher antibodies were required, so more boosters were recommended. The result was that boosting seemed to reduce the risk of infection for shorter and shorter periods of time. Students and the employed had to comply or appeal to avoid being reduced to second-class citizens. Many asked for permission to get medical or religious exemptions. Sometimes they were granted, sometimes not. But COVID infections just kept coming, and they will continue to come. The vaccines are not sterilizing. Herd immunity will depend upon breaking the chain of transmission. The innate immune system, the cellular immune system, and mucosal IgA antibodies might help, but they are elements of the immune system that the current vaccines do not seem to enhance as well as we'd like. So the Omicron BA.5 variant represents an immune escape variant. This slide represents genetic mutations that have occurred in the various variants as the pandemic progressed. The novel vaccines were designed to produce a portion of the spike protein to elicit a specific antibody response, specifically epitopes that were in the receptor binding domain. The intent is to block the virus from entering a cell and then replicating more virus. But here's the evolutionary problem: natural selection. High levels of infectious pressure to a very mutable RNA virus, coupled with a very targeted immune pressure generated by our mass vaccination efforts in the face of a pandemic, results in increasing selection pressure for a new predominant COVID variant that escapes the antibodies produced by our massive public health vaccination effort. In part, recovered immunity can place immune pressure on that as well. But the new escape variant may then evade existing community immunity, and the infection pressure reoccurs, and the cycle continues. We need sterilizing immunity. The current proposed solution is to enter a type of virus vaccine arms race. There are new messenger RNA products that include antigens to the Omicron BA4 and BA5. And another new option is the Novavax vaccine that contains pieces of the viral spike protein and an adjuvant to help promote an immune response. But I share the concern of other immunologists and vaccinologists who believe that this vaccine arms race may result in the convergence of just another new dominant variant of concern. The pandemic progressed through the alpha, the beta, the gamma, the delta, the Omicron variants as we move left to right on this diagram. Most of the genetic mutations to the viral genome are depicted by the orange color and have occurred in this highly important receptor binding domain that was targeted by the vaccine. Immune escape from the vaccinal antibodies have occurred, and the Omicron viral mutations have even evaded the immunity of those who have recovered from previous infections. But fortunately, those with recovered immunity are also protected against severe disease. Remember, those who have had recovered immunity have antibodies to other aspects of the virus besides the very narrow spike protein, and importantly, they have generated mucosal immunity, such as IgA, that reduces their chance of being reinfected compared to those who are vaccinated. Although I'm not suggesting that people go out and try to get infected, although at this point, most of you have been. But if you have been infected, my hope is that you have generated enough IgA immunity to reduce the viral chain of transmission. But let's look a little deeper at viral efficacy during the Omicron variant. This article appeared in the New England Journal of Medicine in June of 2022. It looked at the efficacy of both the Pfizer and Moderna shots to prevent infection to symptomatic Omicron as compared to those with recovered immunity. Let's look at the data at the next slide. So the blue squares on the left of the slide represent those with recovered immunity, and if they are followed for over a month, or over a year rather, and you can see that the efficacy remains fairly flat above 50%. Those in the light green squares represent those that received the initial series of the Pfizer vaccine, and you can see that the trend is negative by 6 months against the Omicron variant. And those that received a booster, just over a month, again in the dark green squares, the trend is again negative. Let's go to the next slide. This represents the Moderna efficacy against Omicron. And again, the blue represents those who have recovered immunity. And again, the effectiveness of their immunity remains flat over the course of over a year. Whereas those who have had an initial series with the Moderna, you can see the trend is negative after 6 months. And likewise with the booster, after 1 month, we see a trend that's negative. Let's go to the next slide. This is data that appeared in the Journal of the American Medical Association. that collected information on children hospitalizations over time, specifically between the transition between the Delta and the Omicron variant for children between the ages of 5 and 11 and 12 and 17. The study compared the vaccinated and the unvaccinated over this time. And what I'm going to draw your attention to is the very bottom of both of these age categories and to the far right. So you see a 99.2, that's the percentage of the infections that were due to the Omicron. And that's what we're interested in. And if you look, as you go down the slide there, the next column over is the percentage of the population that have been vaccinated. But I want to draw your attention to the middle of the slide where it looks at rates per 100,000. So it looks at the number of kids who've been hospitalized per 100,000 between those that are vaccinated and those that are unvaccinated. And if you look at the very bottom of January, the week of January 24th to the 30th, you see that being vaccinated in this population represented a 0.3 per 100,000 decreased risk by being vaccinated to avoid hospitalization for those under age 11, 5 to 11. And for 12 to 17, it was about 1 per 100,000. So the reason I'm sharing this with you is because parents are trying to weigh the risk and benefit. So this is suggesting the reduced risk of hospitalization. I think it's becoming less obvious with the Omicron variant. And so parents are right to ask about the safety data. How much benefit is being answered somewhat with this slide, but what's the risk? And they're asking for transparent, more accurate vaccine safety data. And unfortunately, we have to understand that the long-term consequences to vaccinating children are unknown because the studies are ongoing to this day. Go to the next, So the question that everyone really wants to know is how safe are these vaccines? During my presentation in May, I spoke about the pharmacovigilance programs that are the responsibility of the FDA and the CDC. The feedback loop has been less than ideal. So I will share evidence from governmental sources and peer-reviewed research. People should be able to ask their physicians questions without fear of judgment. The discussion should be more than just safe and effective at this time. A parent may want to consider their child's health conditions, their current immune status, specific age benefit ratio considerations. But again, public shaming and claims that being vaccinated stops transmission to others should not be used to coerce a decision to vaccinate. This is the CDC's Vaccine Adverse Events Reporting System data. This represents the number of deaths reported to VAERS since 1990 and includes all types of vaccinations. The increase in death over the past 2 years is difficult to ignore. More COVID vaccine-associated deaths have been passively reported in the last in 2021 and 2022 than all other vaccinations combined since 1990. Although causality cannot be determined from this data, death is an endpoint that's difficult to misinterpret. At this point in the pandemic, I think there is an obligation for the CDC to provide a thorough analysis of their own safety vigilance system and explain why this information is not a valid concern. The analysis should have been available to the public before mandates were enacted. The VAERS data safety signals have been replicated in the yellow card system in the United Kingdom, the UDRA vigilance system in Europe, and the Vigi Access system that is an international database monitored by the World Health Organization. This represents the US VAERS data about the timing of death after a COVID vaccine. As you can see, most of the deaths occurred within days of receiving the vaccine. Some have suggested that most of these people were going to die anyway. They were expected deaths. But as a physician, it has been my observation that people close to death who expected to die don't usually present for vaccinations. This is a very recent study that is, I think, one of the first attempts to do a harm versus benefit analysis for the Pfizer and Moderna vaccines. They were using the same randomized controlled study groups that were used to gain the emergency use approval from the FDA in late 2020. They measured the excess adverse events of special interest between the vaccinated and the unvaccinated, and also look at the number of hospitalizations that might be reduced. They found a combined 16% higher risk of serious adverse events of special interest in the messenger RNA vaccine recipients, combining both the Pfizer and Moderna. In comparing post-authorization study trials in July of 2021, the FDA reported detecting 4 potential adverse events of interest: pulmonary embolism, acute myocardial infarction, immune thrombocytopenia, and something called disseminated intravascular coagulation following the Pfizer vaccine, based upon medical claims data in older Americans. The FDA said that they would investigate this finding, but the report remains to be seen. The authors conducted a simple harm-benefit comparison using the trial data, comparing excess risk of serious adverse events of interest against reductions in COVID-19 hospitalizations. They found that the excess risk of serious adverse events of special interest exceeded the reduction in the COVID-19 hospitalization in both the Pfizer and Moderna trials. The authors acknowledged limitations to their study. That's important to note. But they also advised that future, more complete analysis will require a public release of the previous participant-level data sets that have been only slowly released because of a Freedom of Information lawsuit against the FDA. I will post the link to this article on our website under Powell's COVID blogs. This is from the CDC website, and I'll draw your attention to the red square. I have concerns about some aspects of the official public messaging during this pandemic. Why did the CDC website change information on July 22nd as it related to how long the spike protein lasts in the body after vaccination? On July 22nd, it says it was for up to a few weeks. What other pharmacokinetic studies, or where have they been done in regards to how long the spike protein lasts after vaccination that informed the CDC to make this observation? If there is evidence, was it done in humans? Was it done in mice? Let's go to the next slide. So this was on July 23rd, the next day. Again, you can see that the statement has been removed. I think the public would be interested as to why that change occurred. I think it was possibly related to a study by Stanford scientists that was published about 4 months earlier. Go to the next slide. This study was a peer-reviewed article, and it was published in the journal Cell. It found evidence of persistent spike protein in messenger RNA in the germinal lymph nodes of humans that had biopsies of their lymph nodes up to 60 days in these vaccinated individuals. We remember that the Salk Institute about a year previously had suggested the spike protein itself could cause adverse effects. I think it would be interesting to understand if this study was indeed the driver for the change. And my hope is that the CDC, if this was the case, would make this a more publicly aware, so people can weigh this in their risk-benefit assessment as to whether or not they want the vaccine. Let's go to the next slide. Yeah. So this was another article that appeared in a journal. It's a peer-reviewed journal. And it complicates the CDC statements that the messenger RNA from these vaccines cannot enter the nucleus of a cell where genetic material is located. This statement by the CDC was provided as evidence that the messenger RNA technology could not change or influence humans' genes. But again, this peer-reviewed published paper by Swedish scientists found evidence in the lab that the messenger RNA from Pfizer, the Pfizer shot, could be reverse transcribed into human liver cell lines. Does the NIH or the CDC or other academic institutions find this peer-reviewed published study credible? Are they trying to replicate the results? Or better yet, are they looking for the evidence of this phenomenon in vaccinated persons? Which specific studies were done prior to the emergency use authorization of these messenger RNA products to make this definitive statement that appears on the CDC website? This article appeared in the Journal of Science, and it raised concerns about immune imprinting and hybrid immune dampening in UK healthcare workers who were infected with the Omicron variant. It seems relevant. These healthcare workers were followed for over the course of the pandemic. They were all vaccinated and boosted with the messenger RNA vaccine. The researchers kept track of what variant the healthcare workers were infected with and noted how their immune system responded to the Omicron variant when they were reinfected. Unfortunately, as is common with studies during this pandemic, they did not include an unvaccinated control group. They did find a troubling imprinting phenomenon that might represent evidence of what might be called original antigenic sin. They found some unexpected hybrid immune dampening effects. The authors found that the Omicron infection boosted the immune responses in all the previous variants of concern, but responses to the Omicron itself were muted. Further, the Omicron infection after the previous wild-type COVID infection failed to boost the neutralizing antibodies and T-cell responses against Omicron, revealing a profound imprinting effect that may explain why frequent reinfections occur in those who have been vaccinated against a non-circulating variant. The UK Office of National Statistics has released an infection survey of just over 1,700 individuals who tested positive for COVID between November 29th and early December. Of those, 115 tested positive for the Omicron variant. The agency found evidence of a positive correlation between the number of vaccinations and the likelihood to be infected with Omicron. There is a concern that this represents evidence of vaccine-enhanced disease. It was a concern before these vaccines were rolled out. And in a letter to the New England Journal of Medicine, Dr. Paul Offit, the chair of the FDA Vaccine Advisory Board, conceded that there is a real concern that these shots are inducing a form of immune suppression. I would argue that it might be more of an immune dysregulation phenomenon, known as original antigenic sin. But even Dr. Fauci warned that vaccine-enhanced infection can and has occurred in the past. This interview occurred just prior to the rollout of these novel messenger RNA vaccines.
The element to safety, and that is if you vaccinate someone and they make an antibody response and then they get exposed and infected, does the response that you induce actually enhance the infection and make it worse? And the only way you'll know that is if you do an extended study, not in a normal volunteer who has no risk of infection, but in people who are out there in a risk situation. This would not be the first time, if it happened, that a vaccine that looked good in initial safety actually made people worse. It was the history of the respiratory syncytial virus vaccine in children, which paradoxically made the children worse. One of the HIV vaccines that we tested several years ago actually made individuals more likely to get infected. So you can't just go out there and give it to a normal volunteer for a phase 1 trial to see if it's safe. That's the fastest that's ever been done. That's the good news. The challenging news is that even at that rocket speed, it's going to take a few months to show that the initial safety is okay, Then you go into a phase 2 trial, which instead of involving 45 people, which we have in the phase 1 trial, it involves hundreds if not thousands of people. That will take another 6 to 8 months to even know if it works. So at the fastest we can go, it's going to take a year to a year and a half to know if we have a vaccine that we can use.
Okay, so I'm going to go, I'm going to let you move on. Yeah, thank you. I'm going to speak briefly about the concept of all-cause mortality as it relates to these vaccinations. I'm going to show a few slides from a presentation provided by a vaccinologist from the Netherlands. His name is Dr. Theo Shedders, and I'll place a link to his presentation on our Evergreen website under the tab Powell's COVID blog. But the question is really simple. How many people died who were vaccinated versus how many unvaccinated died from any cause during the same period of time? At a minimum, differences in mortality based on age demographics would be helpful. For parents and individuals. In his study, he also reviewed the death trends due to COVID-19 over the same time period. The information came from official sources, governmental sources, and these should be readily available now for all citizens in all countries, especially where mandates remain in effect. The pharmaceutical studies used for the emergency use authorization in the US in 2020 did away with the placebo or control group after a few months, so we really can't follow the outcomes in these cohorts prospectively. Fortunately, there are some countries who have robust national databases, and they are willing to compare the vaccinated versus the unvaccinated mortality rate, although oftentimes through a filter. So I'm grateful when independent experts review the data. The findings by these independent scientists have been noted to have some concerning trends, particularly since the beginning of the Omicron variant. I've reviewed these independent reports from the UK, provinces in Canada, and the Netherlands, and they're not all reassuring. 7 nations have suspended the COVID-19 vaccines for younger age groups, reportedly due to an increased risk of myocarditis. But I wonder if they're seeing other concerning trends as well. So what are these? Who are these countries? Sweden, Finland, France, and Germany suspended Moderna for those under the age of 30. Denmark suspended Moderna for those under the age of 18, and Taiwan suspended the second Pfizer vaccines for those between the ages of 12 and 17. Why did these countries weigh the evidence differently than the United States? The FDA has now authorized emergency use authorization for these products for children as young as 6 months of age. At this point, I'm with these other nations. I think more caution is in order. This slide represents COVID mortality and excess mortality in the Netherlands. Excess mortality is really defined as the number of excess deaths above the normal baseline as compared to previous years. This scientist followed the excess mortality throughout the pandemic. And again, he used official government sources. He noted that all-cause mortality and deaths due to COVID began to diverge in the latter part of 2021. And I just want to draw your attention to how that works. So the orange line represents deaths related to COVID, and the black line represents all-cause mortality. So this is towards the end of 2021. Let's go to the next slide. This slide depicts vaccine efficacy among different age groups and all-cause mortality, but the Netherlands rolled out their vaccinations logically based upon age, since that's how you determine risk. The vaccine would be rolled out in waves, and really the figure on the right just corrects for the timing of when the vaccines were administered. So the yellow line is the younger cohort, and they just corrected. And you could see that they're over time, like I showed you with the article in the New England Journal of Medicine, vaccine efficacy had negative trends as time went on. Go to the next slide. This slide plots vaccine efficacy against all-cause mortality. If the vaccine efficacy is correct, then it implies, and I want to make an emphasis on this statement, implies, does not conclude, that after week 43 in the Netherlands, the chance of death was higher in the vaccinated cohort. But what happens if you give a fourth vaccine? And so this vaccinologist looked at that. This is probably the most important slide. This is in 2022. The excess mortality is depicted in the orange. The vaccination timing and the number of vaccinations is depicted by the gray line. And then the background COVID-19 deaths are depicted by the blue. This is a concerning trend. This slide is a screenshot from the Oregon Health Authority website. It represents the weekly excess mortality rate and COVID deaths since March of 2022 through August 20th of this year. It represents the era of the Omicron variant and subtypes. I noticed that the trend of excess deaths seems to be possibly increasing or at least stabilizing, but the COVID deaths are steady or possibly decreasing. What's accounting for these excess deaths? And there's a lot of different potentials. I'm not suggesting it's all vaccines. I know for a fact that I think increased overdose deaths accounts for some of this. I hope someone is doing a deep dive into this data. And I think a lot of people are waiting for that deep dive to occur before they make decisions for their children. Let's go to the next. Other countries are having the same problem. This came from Providence in Canada, Alberta. It has an increase in what we call other ill-defined or unknown causes of mortality. So since 2019 to 2021, you can see that in 2019, unknown was the 10th leading cause of death, but it has become the leading cause of death in 2021, with 6 times plus more deaths in this category. Perhaps politicians and institutions should take a deep breath and step back from definitive statements, policy, and mandates. I think that we should respect the scientific norms of the past. We need to have a full viewing of evidence and encourage unfettered debate among physicians and scientists. We should leave this politicized, top-down, groupthink type of science in the dust where it belongs. And we should allow the free exchange of ideas to repair the reputation of the medical professions. Misinformation will be sorted out by debate, not by censorship, and hopefully not by legislative decree. Importantly, until the data is appropriately vetted, the best policy is not to have one. First, do no harm. It is critical that we never again allow one person or even one institution proclaim that they are the science. We may have to move my head so people can read this, but I will just summarize a few questions that individuals and parents may want to ask their doctor if they are considering their options. I hope this helps. Lastly, I'll leave you with a warning from Carl Sagan, a deceased astrophysicist, author, and communicator of science. He was prophetic in this brief interview clip.
There's 2 kinds of dangers. One is what I just talked about, that we've arranged a society based on science and technology, in which nobody understands anything about science and technology. And this combustible mixture of ignorance and power, sooner or later, is going to blow up in our faces. I mean, who is running the science and technology in a democracy if the people don't know anything about it? And the second reason that I'm worried about this is that science is more than a body of knowledge. It's a way of thinking, a way of skeptically interrogating the universe with a fine understanding of human fallibility. If we something is true, to be skeptical of those in authority, then we're up for grabs.
He was correct. We need to educate ourselves. We need to teach our children how to be skeptical. Critical thinking skills are more important than ever. Science is not a person or an answer. It's a way of thinking. Thank you.
All right, Dr. John, thank you for that presentation. Again, questions on any of the platforms in the chat that are left will be taken a look at by Dr. John and responded to. The frequently asked questions will be the focus in a response that you can find in the Powell blogs at Evergreen Family Medicine. This is Evergreen Talks, the second Thursday of every month at 4 o'clock. You can see another Evergreen Talk and Facebook and other platforms live event where physicians, providers, and specialists present topics that matter to you. And once again, we'd love to direct people to evergreenfamilymedicine.com for more information. This presentation will be posted there as well. And the other information that the Powells have produced for over the last couple of years and even before the pandemic is also available there at evergreenfamilymedicine.com. All right. Thank you, Dr. John.
Thank you, Brian.
And we'll see you in a month at the next Evergreen Talk.
Thank you.